And so I think that first we know we're going to get that. Some critics are saying, Congress is going to roll that back. We're not going to see that money anyway. But I think it's important to keep in mind that given the budget process that we have in Congress and what's called pay-as-you-go, which means that for any new spending you have to have offsetting savings. If there were to be changes to the Medicare provisions in the Affordable Care Act, those would need to be paid for by future Congress. But as I said, I think there's a lot of promise, but a really big challenge that lies beyond those traditional savings. And it's that kind of hard work that, in terms of implementing those provisions, that has a real promise for changing the upward trajectory on healthcare costs. So some provisions that are in the bill, like the high-cost plan tax, economists argue, are also going to help with that. They believe that the likely employer response to having an excise tax on benefits that exceed a certain threshold is that they will end up reducing benefits, which should in turn reduce healthcare utilization among those very well insured individuals, or at least very costly insured individuals, I should say. Other provisions, and particularly delivery system reform, that's where there's a lot of there's a lot that's unknown. There's a lot of work to be done. It's going to require very real cultural change by the Center for Medicare and Medicaid Services. They have new authority to do a lot of demonstrations around how do we change payment systems. How do we bundle payments so that between hospital care and post-hospital care, that there's really a continuum of coordination, that there's a funding that might go to one entity that coordinates with all of the others. That might create incentives for reducing the use of costly medical devices or other kinds of technology. It certainly would create incentives about having a clean handoff between a hospital and a community-based setting where somebody's getting care afterwards, or making sure that in a discharge plan there's very well understood plan of care. But that demonstrating how that's going to work and then getting those kind of pilot programs disseminated very broadly and taken up very quickly in other parts of the country is going to require the agency that runs Medicare to do work in a pretty different way. I also used to work there. I had a great time working there, but I have to say that being nimble and flexible and being able to kind of turn on a dime when the kind of demonstration results that you were expecting don't come through, and making the changes that you need, that's sort of a new skill set that agency needs to develop. Now, I think their nominated new administrator, who is Don Berwick, who's coming from a place called the Institute for Healthcare Improvement in Boston, has a lot of experience about how do you make that kind of change within delivery systems and how do you spread it. I think that's a huge part. That kind of leadership is part of that cultural change, but I think it's going to be a big challenge for Medicare to seize the new authority that they have and really make the most out of it. I think they're very committed to it. I think a lot of organizations like mine are very committed to helping them do it, with coming up with ideas and proposals and partners for them to work with. But to make sure that we can simultaneously save money and improve patients' experience in the delivery system is a very big challenge, and is something that we're going to see how that rolls out. So I think one thing to think about is, where do we want to be once these pieces are rolled out? Certainly, I'm looking forward to having my daughter grow up in a world where it's assumed that you have health insurance coverage, and that she would know that whether she's working for an employer or whether she's working as a consultant or she's a student or whatever, that she has different choices on how she gets her health insurance, and that she's assured of being able to get coverage. But at the same time, we need to think about, what's it going to look like as we control healthcare costs. I think as we think about we should be thinking of how do we lower administrative costs, how do we use the insurance exchanges so that we have a much more efficient market for purchasing health insurance, and simultaneously making sure that people have better coverage than we have now in the individual and small group markets. I think we're going to see the delivery system move away from fee-for-service, where physicians and hospitals and other providers are paid each time they do something, each time they lay hands on people. And by extension, what I think that's going to do is to really move into the greater use of group practices and other kinds of collaboration across providers, so that we're able to have more emphasis on patient management, on using nurses and social workers and other kinds of providers who we know are really important in terms of providing that better quality care and making sure that people who have chronic conditions don't end up in the hospital, but rather get the care that they need at the community level at an earlier and more efficient point in their care trajectory. To make more efficient use of our healthcare resources, we've talked about reduced hospitalization and reduced readmissions. Certainly the better transition to post-acute care, but also shifting more to primary care. Some of the workforce money that's in the bill, I think, is also going to help in terms of directing better payments to primary care physicians and hopefully more medical students into primary care. But that's going to be a huge challenge in front of us, and I think there's going to be much more to come. So I'm going to end there and look forward to questions.